All right, this one I wanted to change up a bit. It's actually a presentation I had made a while back that I thought would just serve as a good kind of foundation for, really reviewing just kind of all things Burns, right? Or not all things Burns, I should say, right? Heavily, I'm going to emphasize the thermal burns, right? But we know there's, radiation burns, there's electrical injuries as well, electrical burns. We're mostly going to be on the thermal burn side and talk a little bit about kind of the pathophysiology, why it's so concerning, just what are some of those complications that we actually run into. I got a few just kind of practice multiple choice questions that are on here to kind of, gauge a little bit of kind of the attention span over the course of the next 2 hours, although those will probably be about midway through. So we're going to review the rule of 9's, review a little bit of the pathophysiology of burns, some of the burn severity scales, right? What's a minor burn versus a moderate burn versus a severe burn, right? So some of the stuff that we're going to cover, and then we're going to wrap it up with the last little segment of doing some fluid resuscitation questions via the Parkland Formula. I know there's Parkland Formula, there's consensus formula. It's all pretty similar. We're going to use Parkland to do that, to calculate how much fluid will we actually be administering over a certain time interval. We're going to factor that out, and we'll be able to figure that part out too. All right, so burns is what we're talking about. Right. There we are. And so, yeah, getting into it, it's really a matter of kind of circling back to the fact that, if we're talking about a thermal burn, right, some sort of surface burn, right, so it's worthwhile going back into the skin anatomy section, right, and talking about what's that function of, whoops, let's see here. Cool. All right, yeah, question came through. Yeah, these are recorded, so I will get them up there for you, absolutely. All right, so skin anatomy, right? We're talking about a burn, so we're talking about a breakdown, a destruction, a compromise in the integrity of the skin, right? And so we have that, idea of, okay, let's circle back to, before we talk about breaking down the skin and what's going to go wrong with it, let's actually talk about what's it doing for us when everything's good and functioning proper, right? So going through the functions of the skin, right? Skin is really good at keeping the outside stuff outside the body and the inside stuff inside the body, right? I mean, at its core, I mean, at the kind of base foundation, right? It holds a lot of the stuff in, a lot of the moisture, a lot of the heat that the body naturally has, right? It keeps that in when it needs to, and it releases it when it needs to, right? It releases it when it needs to as well. So we have that ability to increase blood flow via vasodilation, right? Increase blood flow to the surface, and we have that ability to vasoconstrict in those blood vessels to shunt that blood away from the surface and shunt it back to the core, right? So it's really kind of this back and forth of heat distribution inside the body, based on the internal environment. Are we too hot or too cold internally? And then also based off of the outside environment, right? Is it hotter or colder than us, right? Because heat's going to go hot to cold, right? If we touch something that's hot and it's hotter than our body temperature, that heat is going to move from that object to, our hand if we're touching it, right? And then the opposite's true. If we're touching something cold, right, colder than our body temperature, heat is going to go hot to cold, right? Heat's going to transmit that way. So going through it, right, that's again kind of at its core initially is that ability to keep the outside stuff outside the body, the inside stuff inside the body, right? But it's when we get some sort of break in the skin, right, that's when we start running into that situation of, hey, the outside stuff can now enter the body and that inside stuff that we want to stay inside can now leave the body, right? So it all goes back to that level, right? But going through some of the kind of layers of the skin, right? And it's always kind of these same three from the outside in, right? We have the epidermis, right? That very kind of superficial top layer. And then we have the thicker dermis layer is the next one. And then subcutaneous tissue below it, right? Below the skin, subcutaneous, And below that, we have the membrane that wraps around muscles called fascia. It's where we'll circle back to in a little bit. Below the fascia is the muscle. Below the muscle, there's a membrane called the periosteum that's wrapped around bone. Peri is around, osteum is the bone. So we got another membrane there, and then we got the bone all the way down, right? If we were working our way through all of the different layers. Right? But very, very, very superficially on the top, right? You can kind of, think about it. Have you ever got that paper cut where you can see the little flap of skin, but it doesn't hurt, right? Not those paper clips or paper cuts that make you want to scream and cry, right? Just that very superficial one where you can see the flap of skin, but it doesn't hurt at all, right? That's a very superficial, right, cut just in that epidermis layer, right? Just in that epidermis layer, that fairly just top layer of cells. Right? Below that epidermis layer in the dermis, that's where you get your nerves, right? A lot of the blood vessels, right? A lot of the blood vessels that are going in there, right? So that's the cut that bleeds, right? It starts to hurt is because it's deep enough into those layers that it's, hitting the nerves, hitting the blood vessels, hitting some of those other structures. Right, so super small little kind of layer difference. Right? So you can think about your skin, right? It's not that thick before you start getting down to muscle and bone and other tissues below that. So a little bit of the review of kind of some of those structures, but this is going to come back up into play for us with burns, where we talk about burns that are really, really painful, and then a really, really, really bad burn that might not actually be painful, right? And it's related to the depth of that burn, how deep it's actually gone through and damaged those tissues. All right, so heat and energy is what we're talking about, right? The transfer of heat and the transfer of energy, right? Heat or energy, you can kind of use them interchangeably here. Right? So we got to think about it in terms of our natural body temperature, 98.6 degrees Fahrenheit, roughly, right? And the reason why we're cooking along pretty warm when you actually think about it, right? Although not here in Arizona where it's like 140 degrees outside all the time, right? We're cooking along at 98.6 degrees, right? Kind of back to one of those concepts from this morning, if you're watching that, with the perfusion, right? And that cellular metabolism. Right? We said the cellular metabolism where we use up oxygen, right? In an effort to make energy, or ATP is the energy, right? And then that waste product was carbon dioxide, right? That's kind of the goal of all the cells staying alive, is they use oxygen and sugar, right? Oxygen and sugar to make energy, right? And then they make the waste products that our body's going to eliminate, right? But with the creation of that energy, ATP, is the creation of heat, right? It's one of the reasons why in shock, right, as the problem gets worse and worse and worse, we'll actually go hypothermic, right? Because as we start having less oxygen in the system, we start making less energy, we start making less heat internally. So we start to go cold as that hypothermia actually, or as that shock actually progresses, right? So heat is a byproduct of cellular metabolism, right? Every single cell actually doing the things that those cells need to do to stay alive, right? It's a creation of heat. And so when we take it on all the, millions and billions of cells throughout the body, right? All of those cells doing the things that they need to do to stay alive, to make energy, right? It makes heat, right? All of those things collectively bring us up to around about that normal body temperature. Right, but it's actually all the way down to each individual cell. Right, so that's where our heat is coming from. And so then we said it's a transfer of heat, or a transfer of that energy, but it's a transfer of that heat, and it is going to go hot to cold, right? Hot to cold. If we touch something that's hotter, it's going to go from that hot object to us, and it's going to burn us. Right? If we touch something that's colder, it's going to go from the warmer us to that colder object. Right? That's why our hand gets cold, is because that energy, that heat is actually leaving it, being transmitted to that colder object. So when we get into the burns, When we start talking about burn severity, it's really the amount plus the duration, right? So the amount of heat, just how hot is whatever it is that we're coming into contact with, whether it's a flame or we touch the oven or you took a glass out of the microwave and that glass was too hot, right? Just how much heat does it have? And then the duration is the duration of time that we were in contact with it, or we were exposed to that heat source, right? Or that energy source, if we were talking about radiation or something like that, right? So the amount of heat or energy and the duration of time that we were exposed to it. The longer the duration of time, the more severe that burn's going to be, right? The greater the amount of heat, the more severe that burn's going to be, right? Really, really hot and being exposed for a prolonged period of time, obviously going to be a really bad burn in that situation, right? So it's all about the amount of the energy plus the duration. Now we're going to touch on some stuff with pediatrics in this as well tonight. But in pediatrics, right, generally what we talk about is, you know, their skin is comparatively a lot thinner than an otherwise, you know, healthy adult, right? So that heat energy is going to transmit through the layers and it's going to damage the layers of the skin faster in a pediatric patient than an adult patient because that skin is thinner, so it's able to move through the layers faster. Right? Same thing on the flip side, potentially, with some geriatric patients. Sometimes you get some thinner skin as well, and that heat is going to transmit through quicker. So it also comes into play is what kind of patient are we talking about? Because we could have an amount of heat and a duration of time that's the exact same for an adult as it is for a pediatric patient, and that pediatric patient is going to be a more severe burn, even though they might have been exposed to the exact same amount of heat and for the exact same amount of time as an adult, right? Because of that anatomy difference of the thinner layers of the skin, we actually get a more severe burn in those patients with it. So some of the kind of things that we're going to start talking about in this one. All right, so what happens in burns? We start burning and damage, right? Or we say compromise the integrity of the skin. Okay? One of the things that starts happening, and really anytime we start talking about trauma and soft tissue trauma, whether it's a blunt force trauma or a penetrating thing or a burn, right? Anytime we get that trauma, some of the stuff that starts happening is tissue swells, right? Anytime we have that injury to the body, tissue is generally going to swell. And that swelling or edema is fluid shifting, right? Is fluid shifting. And so we have to think about it with kind of the fact of, okay, where is this fluid actually coming from? So if we say fluid is moving around, we have edema that's swelling, right? It's not just spontaneously creating fluid inside that tissue. That fluid has to come from somewhere, right? And so there's 3 places that we have fluid inside the body. Right? We have fluid in the bloodstream, right? And we call that intravascular. Right? It's inside the blood vessels. So we've got some fluid that's inside the bloodstream. Right? We know that one. That makes sense. And we have fluid that's, let's say, inside the cells. Right? Inside the cells. And we call that intracellular. So we have fluid inside the blood vessels, intravascular, and inside the cells, intracellular. And then we have one more space. We actually have fluid between the cells. As every single cell in the body is not just like cement stuck to the one next to it, there's a little bit of fluid in between those cells. And that space we call the interstitial space. Not as obvious a word as the other ones, right? Interstitial is that space between the cells. Right? Now collectively, I wasn't planning on going here, but collectively, this good terminology We have intracellular, it's inside the cells. These two compartments are considered extracellular. So we have fluid inside the cells and we have fluid outside the cells. The fluid outside the cells, extracellular, can be in one of two places. It can be between the cells or it can be in the bloodstream. So if you ever hear them talking intracellular fluid versus extracellular fluid, intra is inside the cells, extra is outside the cells, so it's those two compartments. So what happens when we damage the skin and we get those burns, right? Fluid starts shifting into the tissues, right? Into this interstitial space. Right? So some fluid shifts from the bloodstream into the tissue, right? And some fluid may actually shift outside of the cells. Right? May move outside of the cells as well. Right? So that fluid starts building up, right, in the tissue, right, in that interstitial space, as we get a buildup of fluid. And when we think about kind of vital signs here, just kind of pivoting to a level that we will think about a little bit more, on the vital signs, right, we measure blood pressure as a pressure of that blood moving through the blood vessels. So if some of that fluid has left the bloodstream to go into the cells, the tendency is for that blood pressure to start dropping, right? Is because that fluid is actually leaving the cells. Even though the overall body hasn't lost any fluid, it's just in the wrong spot now, right? So it's supposed to be in the bloodstream, but some of that leaked out into the cells, right? So it's still inside the body, but it's in the wrong spot, right? Sometimes they may give that a term called relative hypovolemia, right? Because the whole body hasn't lost fluid, but it's in the wrong spot, right? It might be a relative hypovolemia. Okay. All right, so fluid shifting is one of the big things that progresses, right? That's why if we have a burn involving the airway, right, it's a big deal, right? That airway, there's only a finite amount of geography up there. If it starts to swell, it's going to close off entirely, right? So airway assessment is one of the critical things if we have any sort of indication that there's a burn in or around, you know, the face or head at all, is we get real aggressive on airway management really quickly, right? It can be one of those few kind of registry style scenario questions that might actually be an early aggressive push towards intubation. Normally on the ALS side, we say you have to go BLS before ALS, right? And that's still true. It's just how quickly are we going to move there, right? So there's two situations, right? There's the burn involving the airway and there's anaphylaxis where you get airway swelling, are the two situations where they really talk about early aggressive airway management. Right? So kind of side note there on that one. Right, so this fluid shifting happens, right? And we call it third spacing, right? Is the fluid moves from the bloodstream into the tissues and from the cells into the tissues, right? And we don't really talk about that space too often, so it's the third one. It's the third space. It's the space in between the cells, and we actually call that fluid shifting thing that's happening is third spacing of fluid. Right? It's one of the things that can actually push us to compartment syndrome with burns, is as that tissue that was really severely burned, as that tissue really keeps swelling, right? It's in a closed container still. The skin's only going to stretch so much before it's kind of stretched to capacity. And now that pressure that's inside is going to start squeezing down on nerves, squeezing down on blood vessels, and it's going to cut off circulation to that tissue past it. That's kind of the severe progression of this third spacing problem, is that it actually kind of serves like an internal tourniquet, right? It cuts off blood flow to that tissue that's past that swelling, right? That's why at a burn center, they'll go and do what's called a fasciotomy or an escharotomy, where they'll actually do scalpel incisions on the skin that's swollen to allow for that fluid to leak out. so that it doesn't build up and cause that compartment syndrome and cut off circulation. Is they'll actually do big incisions. If it's a big burn on the chest, they may have big incisions down the chest, just kind of allowing that fluid to leak out a little bit, right? So it doesn't kind of build up that pressure and start causing that compartment syndrome. All right. So other things that are going on, I don't want to go to the types of burns yet. All right, so we have this fluid shifting problem that's happening. One of the other things that we said is going on with the skin is the skin, with that ability to vasodilate and vasoconstrict, really helps keep the internal warmth of our body inside. Right? So if we have a big severe burn and we've kind of lost that function of the skin to kind of keep everything inside, what happens, it's almost counterintuitive. And you've got somebody that's been severely burned, but what happens is with that tissue, it starts radiating off all of this heat from our body, right? So they were burned, damaged all the skin, and they're going hypothermic. Right? These burn patients can actually go hypothermic very quickly. And it's because it depends on how much tissue has actually been burned. And again, that skin is normally able to help keep that warmth inside. If we burn all of the skin severely, we're just we have no ability to keep that warmth inside. So we start radiating off tremendous amounts of heat and we'll go hypothermic. So we have this fluid shifting that's happening, that's making them hypotensive and dehydrated, right? Because of that fluid leaving the bloodstream. Right? So we've got this hypovolemic, hypotensive situation. We have this compartment syndrome potential that's going to happen. We also right now have this big hypothermia situation going on. And so you see these really bad burns start to cause a lot of problems. Beyond even, getting to an airway swelling shut or anything like that. So hypovolemia, hypotension, hypothermia. And we said the skin is normally good at keeping outside stuff outside. So when we burn the skin and we kind of lose that function, now it's a huge risk of infection. Right? So we've got the low blood pressure, hypovolemia. Right? We've got the hypothermia, low temperature, and now we're big time infection risk. Right? It's kind of the three-headed monster, so to speak, of a severe burn. Right? Blood pressure and temperature going to be much more acute, right? That's probably something that we're going to run into a little bit more in the emergency setting, right? Is dealing with that hypotension and the hypothermia where, we have this burn patient, but we actually have to make sure we're keeping them warm because their body is losing all that heat. A little bit later, right, at the hospital, right, huge concerns for infections, right? Because now the skin, we've lost that first line of defense of the immune system, which is the skin being able to keep that stuff outside the body in the first place. Good. All right. So fluid compartments, again, that's where compartment syndrome is going to come for. So let's talk our types of burns. Right? So they, for a good little chunk of time now, they've really moved away from the first degree, second degree, third degree burn categories. Right? Even most of the textbooks, they still say, right? They'll say superficial burns, in parentheses, they'll say first degree. They still put it there because, most people coming into school still have those terms a little bit more readily available. And so they kind of relate it to that terminology, but they've really shifted us more to the superficial, partial thickness, and full thickness burns. Previously, the first degree, second degree, and third degree burns. Okay. So a little bit, we got to look at layers, and we got to look at, what are some of those unique things for how we're actually going to be able to identify it on like a test question, scenario, stuff like that. Being able to say, this is a superficial versus a partial thickness versus something else. Right? So on the superficial burn, right, kind of the easiest analogy for a lot of us is a sunburn, right? at least for me, I can just think about the sun and I'll turn as red as a lobster, right? I burn very easily, right? So that's a superficial burn, right? It's just that outer layer of the skin is what has actually been burned, right? So you get redness, generally pretty painful, right? And sometimes you can actually see the blanching, right? If you touch on it, get a little pale right there and slowly kind of turns red again, right? That's what I look like when I get a sunburn, right? One of the key things though, for whatever reason, they always like to emphasize, are there blisters or are there no blisters? And so it's a simple thing to identify if you have a scenario question and they say blisters, automatically it's not a superficial burn, right? If it starts blistering, that pushes it to the next category, right? So red, painful, no blisters, right? It's a sunburn, or really light, really superficial, right? That's where the word came from, right? Very superficial. Okay? Going into the second degree burns, right? Second degree, now, again, partial thickness, right? Partial thickness. Painful, yep. Red skin again, yes. Maybe some other colors, right? Maybe mottled or splotchy or white. Right? So still could be red, could be some other colors, right? But then the big kind of determinant from the superficial to the partial thickness is this does have the blisters, right? And that's what you're seeing there on this guy's back, right? Those are all those swelled up kind of tissue spots. Now we got to think about that. Yeah. These blisters are full of fluid. It's like, all right, well, where did that fluid come from? Right. It's fluid shifting out of the cells, right, that have been damaged into the tissue, right, into the third space, right, into the tissue. Right, so that's how we get blisters, right? It's that fluid shifting, right? On a bad enough burn, it's fluid shifting on a bigger scale than just kind of some isolated blister spots. Right? But again, that's the same thing. That fluid, again, the fluid didn't get created magically inside the body. It just moved from a different area where it was, right? It moved into the tissues and we get blisters. Remember, one of the things that they always tell us, don't pop blisters. Right? Even though a lot of us, we get a blister, we pop it. Right? Ever notice that a lot of the stuff that we were taught when we were told when we were kids is like the exact opposite of what we're supposed to do as EMTs and paramedics? Right? I know I get a blister and I still do the same thing. I pinch it and pop it. Right? For us, we don't pop the blisters. Right? I know nosebleeds was another one. There's a pure just side note. Right? Nosebleeds was another one. Right? When I was a kid, it was pinch your nose, head back. Right? Then get that blood that drains into the back of your throat. EMT paramedic school, pinch your nose, head forward. Right? The exact opposite. But somehow, we're all still alive, right? So partial thickness or second degree burns, biggest part is the blistering, right? Still painful. And then again, you may have some skin color changes, and you can see the superficial was really just that epidermis layer. Partial thickness is now getting deeper, right? It's getting down into those deeper layers where the nerves and the blood vessels are. Right? That's why it's probably going to be even more painful, right? Even more issues going on with it. All right, and then our third degree burns, our full thickness burns. Right? It says all layers of the skin, right? So through the epidermis, through the dermis, likely even through a lot of that subcutaneous tissue as well. White to charred skin, right? And the key one with this is they will say the full thickness burn is not painful, which again is one of those ones that can kind of sound counterintuitive, but it's a good review one. Right? So if we, we're able to just kind of take, some person's arm there, one more finger. I want some person's arm there. If there was just an isolated full thickness burn that burned through all of the skin layers, right? it burns through the epidermis. It burned all the way through the dermis as well. And the dermis, we said, is where the blood vessels are, but also where those nerves were, right? And we need those nerves intact to be able to process that sensation of pain, right? So by burning through all of the nerves, along with all those layers of skin tissue, we burn through all those nerves, means we're not feeling anything that's there, right? We're not feeling anything that's there, right? So just an isolated, somehow isolated full thickness burn would be considered not painful. Right? That's the key, not painful, charred skin, all the layers, right? And draw a little bit bigger picture here, right? But what we have to remember is around this 3rd degree burn, right? That tissue that's surrounding it is a partial thickness burn more than likely. Okay? And we said that one is very painful. And surrounding that partial thickness burn is probably a superficial burn, which is also painful. Right? So while yes, it's true, this full thickness burn spot that's right there might not actually be processing pain. Again, it's going to be hard for us to kind of think about a scenario in which they just have a 3rd degree full thickness burn, but not also partial thickness burn and superficial thickness burn tissue around it, right? So yes, that spot might not be painful, but everything around it's going to be. Right? But again, registry scenario questions, you got to go black and white with these questions, right? If they say it's a full thickness burn, then it's not painful. Right? That's one of the key ones that they link up with it there. Let's see, there's a question coming through here. All right, question. Is there a classification for a burn that goes down to the bone? Cool. Yeah, you actually hit the nail on the head. Oftentimes, the superficial, partial thickness, and full thickness, or 1st degree, 2nd degree, 3rd degree, is typically the limit that we talk about most of the time. Although they will say if it's just burned all the way through, right, burned to the bone, all of that tissue is gone, burned all the way down to the bone, then they will generally say something like a 4th degree burn, right? Not something that really gets emphasized a lot in the textbooks or anything like that really that I can think of. So most of it we should kind of focus, and certainly if you're in study mode and everything, you got to prioritize stuff, right? I prioritize it more on the superficial, partial thickness, and full thickness, right? Just understand, yeah, they may actually, you know, if you push even beyond the full thickness and say, okay, all the skin layers, all the way down to the bone is burned too, right? All the way through, then just add a number on top of it and we'll go up to our 4th degree burn for it. Yeah, it's a good question. All right, so those are burn types. Right? We got burn zones. And we have a burn severity later. Right? So burn types, burn zones, burn severity, right? All sorts of different things. Right? Burn zones is like a paragraph in the book, and they really kind of gloss over it beyond that. Right? But it's kind of like I just said, we have a burn and we have less damaged tissue around it, and we have less damaged tissue around that. Right? So it's kind of these layers of burns. If you go back to the cardiology and you look at infarctions, right, we have a similar concept. Right? As we say, we have the infarction, the dead tissue spot, and surrounding the dead tissue is injured tissue, and surrounding the injured tissue is ischemic tissue. Right? So dead tissue, injured, ischemic, right? Really bad, less bad, less bad, right? So that's what it is on cardiology for things like an MI. On burns, though, right? On burns, we have different terms, fancy terms, right? But the middle of a burn that's most severe is the zone of coagulation. Right? Right? Same with like coagulation. Right? Like blood, when it pools together, we say that blood coagulates. It gets all clumpy and gross. Right? So that's the worst. That's the middle spot of a burn. That's the most severe zone, is that tissue is actually coagulating. Right? So zone of coagulation is the middle of it. The less severe area around it, they call the zone of stasis. Okay? Zone of stasis. So it hasn't progressed to the point that that tissue is coagulating, but it's in bad shape. It's headed that direction. Right? So zone of stasis. And then surrounding it, right, right, is the zone of hyperemia. Emia is blood, hyper is a lot of, right? So it's really kind of that reddened tissue spot, right? That increased blood flow to that tissue, right? So most severe, zone of coagulation in the middle, less severe, zone of stasis around it, and less severe, even from that, is the zone of hyperemia on the outside. Everything outside the zone of hyperemia is okay. That tissue is fine. Right? So that's what they say, like for the area of the burned spot, everything else is okay. Hyperemia, stasis, coagulation, down to the middle. Right? All right. Now burn severity. Right? Take us probably about up to the hour mark, which will be good. We'll take a little break and we'll shift gears after that. So burn severity, right? Lots of different ones. Some of these numbers may vary ever so slightly, you know, book to book. So always redirect it, but these numbers should be good for you. So burn severity, anything that's circumferential, anything that's circumferential means it's burned where that burn is actually all the way around, like an extremity, or a burn all the way around their trunk. Right? But if we thought if it was going all the way around, if we burn that tissue all the way around, all of that tissue is going to swell. And remember what we said, it's going to start to squeeze down and cause that compartment syndrome. It's going to cut off circulation because all of that tissue is going to swell. Right? If it's not circumferential, well, that tissue is going to swell, but not the tissue on the other side. So we should still be getting good blood flow and everything to that extremity. Okay? But when it is circumferential, all of that tissue is going to start swelling. It'll cut off circulation much faster. All right, so any sort of circumferential burn, boom, severe, right off the bat. Okay? After that, a full thickness burn or a third degree burn, greater than 10% of total body surface area. Okay? So sometimes you'll see total body surface area, TBSA. Okay? Sometimes they will say TBSA-B, just to go a step further and specify what we're actually talking about, which is total body surface area burned. Okay? It's a bit redundant. If we're talking about a burned patient, everybody's going to know that when you're talking about the total body surface area percentage, we're talking about the burned percentage. So TBSA or TBSA-B, again, total body surface area burned percentage. Okay? So greater than 10% of a full thickness burn, greater than 10% of their whole body, full thickness burn is classified as severe. Okay? A partial thickness greater than 30% of the total body is considered severe. Remember, this is any of them. Right? So if they have just a superficial burn, but they have one burn that's circumferential, it's considered a severe burn patient. Right? It's not that they have to have all of these bullet points to be considered severe. Any one of them makes it a severe burn by definition. So partial thickness greater than 30. Right? Burns complicated by a fracture. Right? Again, their body took enough of an insult and an injury by being burned severely but now they've also got some broken bones on it on top of it, right? It's just one bad problem on top of another bad problem, right? So not only is it a burn, but they've got a burn and a fracture, right? Let's bump it up. Their body has dealt with a lot, right? It got burned, but it also took enough force to break some bones as well, right? That body experienced a lot. Let's put them in the severe category. For a patient less than 5 years old or greater than 55 years old, and only a moderate burn, which is going to be the next slide. Okay? So if it's not one of these severe burn categories, it's actually a moderate burn, so not as bad, but because they're young, less than 5, or older, greater than 55, we bump it up a severity scale. So we move it up from a moderate to a severe burn just because of the age. And it goes back to what I said on really that first slide, which is the pediatric patients and some of the geriatric patients, not that 55 is geriatric, don't, yell at me, right? But the pediatric patients and the older patients generally have thinner skin, so that heat severity transmits faster. It's going to make it a more severe burn, requiring less heat and less duration. It'll be a more severe burn, right? So if we take a moderate burn, make them young or old for your patient, we're going to bump it up to a severe burn category. Now, the last one up here, I skipped over the first bullet point. Say the face, right? A burn involving the face, or really a concern for the burn involving the airway. That is what we're talking about. Right, a burn involving the airway is that one that we said is that airway, as that tissue swells, just like any burned tissue swells, that airway is going to swell. We don't have a whole lot of space up there. There's not a whole lot of stretch and flex and give for it. So when that tissue starts swelling, that airway is going to close up really fast. Right? So if they have a burn involving their face, burn involving the airway, really severe right off the bat, regardless of what real type of burn it is. The other ones, hands, feet, on the face with the eyes and nose and some other stuff, but hands, feet, face, genitals is, with the exception of the airway swelling shut, which will kill you quickly, the other stuff with the hands, feet, the rest of the face and the genitals, isn't that it's life-threatening, but more so that it's quality of life threatening. Right? So it's not that you get a burned hand, it's, it's not likely going to kill you, but it's got big time quality of life implications if that's a bit severe burn of your hand or a severe burn of your feet or your face, just because of the kind of social dynamic and psychology, right? Or if you burn your eyes and you actually can't see anymore, now you're blind, or you burn your nose and you can't smell anything or hear anything anymore, right? And genitals certainly as well, right? So big quality of life-threatening injuries. Right? So not that they're all going to kill you, but a big-time impact to quality of life. So they make those a severe burn so that they can really make sure that they do everything that they can possible to protect those structures as much as they can because of those long-term implications. Right? And it's something that you see in severe burn patients, right? That recovery afterwards. Right? Oftentimes they start dealing with, issues like depression and kind of social isolation because maybe they are, scared to kind of show their burns out in public, right? Or they feel kind of shame or insecure about it or something like that. So a lot of times the kind of, down the road stuff just becomes a lot of the psychology side of it. So the hands, feet, face, genitals, not again, that is life-threatening, but more so quality of life-threatening and some of that stuff that we might actually see. All right. So moderate burns, right? Not as long of a list, which is nice, right? A little bit less severe than our severe burns, right? So a severe burn was greater than 10%. So a moderate burn is 2 to 10% of that full thickness. Okay? A severe burn was greater than 30% partial thickness. So we've got less than 30%, 15 to 30, considered a moderate burn. Or a superficial burn greater than half of their overall body. is considered moderate. You see, severe, right? There was no superficial burn that could push you into severe. A superficial burn wasn't on the list for severe. It did make the list for moderate. So superficial greater than 50% of their whole body, half their whole body is superficial burn. Now remember, these moderate burns, if they're less than 5 years old or greater than 55 years old with one of these, right, then remember we actually bump that up to a severe burn status. Right? So if they're 5 with a 2% full thickness burn, it's no longer moderate, it's severe now. Right? So this list for the young and old pushes to severe. Right? Otherwise, it's a moderate burn. So we got severe, moderate, and now minor. Right? Minor, they do have a full thickness burn, but less than 2% of their overall body. Okay. They have a partial thickness burn, less than that 15% cutoff, or superficial anywhere less than that 50%. Right? So might be a good way, a good exercise you could do to try to help remember this. Maybe flashcards. I'm a big flashcard person. Is you could put just types of burns on one side of the card, and on the other side of the card, put minor or moderate or severe. Right? So you could look at the card and you could say, okay, full thickness burn, 2 to 10%. That's a moderate burn. Right? Check the back of it. Right? That can help just, do a couple of reps of some flashcards like that periodically, and it'll really kind of drive in these burn severity percentages, where it's less than 2, 2 to 10, greater than 10. Less than 15, 15 to 30, greater than 30. Less than 50, greater than 50% for superficial, right? That was 3, 6, 7, 8 flashcards, plus a couple more for the other severe burn ones, right? Dozen flashcards, do those a few times, you're gonna be good to go. All right. So a little bit extra, right, on the severity side. On pediatrics, I said everything kind of got bumped up a little bit. Right? So we had specifically that less than 5 with the moderate one, right? But then a lot of books will just kind of pull out all pediatrics. Right? They'll say any full thickness burn in a pediatric patient, partial thickness greater than 20 for severe, moderate is partial thickness 10 to 20, minor, partial thickness less than 10. A little bit of some conflicts, right, between some of these numbers and things. Right, so it may be just you kind of pull out a little bit your pediatric burn percentages and say, okay, for adult moderate partial thickness, it was 15 to 30. So you can kind of do that kind of cross comparison, or make a little flashcard or a little table in your study notes and stuff like that for my adult percentages versus my pediatric percentages. They're all close. It's a nice part. They're all close. So it's not like you got to, memorize drastically different numbers. They're all at least pretty close together. Jumping right back into it. The Palmar method or rule of palms, a little bit, some kind of contentious wiggle room. So it depends on the book is what I'm saying with this one. All right. So one of it says the patient's palm is roughly 1% of, again, remember, their total body surface area. So 1% of the surface area of your entire body, about 1% is your palm. Now the question becomes, what's considered the palm in this, right? I'll tell you what I was taught. I was taught is it's the palm is 1%, just the palm of your hand. Other people started telling me, dude, the palm includes the fingers, okay? And it's actually that total amount, the palm, the hand part and your fingers is actually 1%. And I was like, that's insane. It's the palm, right? And so I went digging, right? And went kind of looking for it. And I found, lo and behold, a whole lot of confusion around it. So go back to what your book says, right? Even across the books that we use, our EMT book says, my flip-flopping, forgive me. I believe our EMT book says it includes the fingers, the hand and the fingers is 1%, but then our paramedic textbook says it's just the palm, not including the fingers, right? And you go online and you just type in rule of palms for burns or body surface area percentage, you'll find a bunch that say one and a bunch that say the other. So my kind of simplified step back answer for you is go with whatever one your book says, and know that because of the confusion variability, right? Because of the confusion variability, you wouldn't get both answers on like National Registry, right? If it's not unanimous that the rule of palms is this versus that, or that versus that, means one answer couldn't be just the hand and another answer be the hand and the fingers, because then it would kind of depend on who you talk to, right? Some people might say this one, some people might say that one. So they'll just go back and they'll say the patient's palm is how much of their total body surface area. They won't define what they actually mean by the palm. And that, again, you can take away as roughly 1%. So I wish I had a better answer. I hate when there's, not as clear of an answer like that. But this is one that I've run into. And like I said, it's for our EMT and our paramedic programs, the textbook publisher is the same. It's the same textbook publisher. One book says the rule of palms includes the fingers. One book says the rule of palms does not include the fingers. Now remember as well, it's the patient's palm is 1% of their body surface area. So don't use your palm and go try to figure it out on a patient, right? You got to adjust for the patient's size. And so the patient's palm is 1% of their total body surface area. So that's a real simplified one, right? That works well for small burns, right? And it works well for odd shaped burns, right? Or if it's not like a whole arm or whatever, it's like, well, we have this burn that kind of just wraps around their arm. It's like, well, 1 palm, 2 palm, 3 palm, 4 palm, that's a 4% burn, right? That's how you can kind of look at it. So small or kind of odd shaped burns that don't kind of cover a big portion of the body or something like that is really kind of the best one to use this Palmar method or rule of palms. Oddly enough, I think it's actually the terminology is where that split came from. Because Palmar, I think, references that whole side, which includes the fingers, but palm generally references just the hand. So I think that might actually be the Palmar method versus rule of palms. It might actually have been the terminology thing kind of bred that confusion. Right? All right, rule of 9's though. We're going to do rule of 9's up here for an adult. We'll talk about a pediatric patient later. But rule of 9's, the head, 9%. Change color on here. Red doesn't show up on the blue as well for us. So the head is 9%. Years ago, like 4 years ago, I was teaching a medic class, and we were reviewing this together as a class. And I started off with a head, and I said, okay, what percentage is a head? And one kid, he was adamant. He's like, 8%. And I was like, 8? It's rule of 9's, not 8's, rule of 9's, right? So it's all based on that 9%, right? So 9% for the head, right? Which includes the face. Right? It's a common spot that will confuse people, right? They might say the head and face is burned. That's still 9%. It looks like they're adding stuff because they're saying the head and the face, so it must be more of a percentage, but it's not. 9% is the whole head, including the face. right? That's such a common little kind of subtle thing that gets slid into test questions that screws students up, right? Is when they say the head and face is burned. People are like, well, the head is 9, so the face must be, 9 again or 4.5, and they start adding numbers to it and they make it bigger than it actually is. Okay? So if they say the head, it's 9%. If they say it's the head and face, it's 9%. If they said just the face, then I would do just half of the overall head. So if the whole head is 9%, including the face, just the face, right? I would say 4.5% if they specified very, very clearly just the face is burned. I would do half of that 9%, half of the head, right? Race eggs, I don't want it to be confusing as we keep laying it out. Okay? So the entire head and the face is 9%. Okay? Each whole arm is 9%. Right? Whole arm, 9%. So that's the upper arm and the lower arm, the front of the arm and the back of the arm, the entire arm is 9%, each of them. Each of them is 9%. So again, that's where you can just, like, when we start doing the rule 9s, all you do is just keep cutting stuff in half. So if they say the anterior left arm is burned, so just the front anterior, just the front of the left arm is burned. Well, if the front and the back is 9%, just the front would be 4.5. Right? Hopefully that makes sense. If they say just the circumferential forearm, well, circumferential is front and back, right? The whole forearm, but not the upper arm. So circumferential front and back entire arm is 9%. So if we just kind of cut the arm in half, circumferential front and back forearm would be 4.5%. Right? So you can just kind of keep chopping up these segments down to figure out what it is. Okay. Each whole leg is 18%. Okay. Whole leg, 18%. Same thing as the arms, the entire whole leg. The entire front of the leg, the entire back of the leg, the upper leg, the lower leg, all of it is 18% for the one leg, 18% for the other leg. Cool. So same thing if they say just the anterior left leg, well, the whole left leg is 18%, so just the front of the left leg, the anterior left leg would be 9%. Just half of the whole amount. Hopefully that makes sense. You just keep cutting stuff in half. You just got to read very carefully. Right? You got to read them very carefully. Okay. All right. Genitals, they'll say 1% because we have to round it off to 100% here in a little bit. So other than the head and face kind of confusing point, the other part that will breed confusion will be the torso. That torso is 18%, and the entire whole back is 18% as well. Now, why I say that causes confusion is because they'll phrase questions and they'll say stuff like, the chest is burned. And people think, chest, torso, 18%. Mm-hmm. Chest, abdomen, 9% for the chest, 9% for the abdomen. Right? So again, the chest does not mean the entire torso. The torso is the chest and abdomen. So if they say just the chest is burned, we have to take half. We got to do 9% off that total 18%. Same thing on the back. If they said the upper back is burned, well, the entire back is 18%. So the upper back, 9%. Lower back, 9%. Right? So the head and face is the one confusing part, and saying the chest is burned or saying the abdomen is burned is the other part where they'll try to throw you off a little bit. Right? Not that they're trying to confuse you, they just want to see if you actually understand these percentages and the regions that they're referencing. Right? Nobody on registry is trying to confuse people. Right? The questions on the registry were written by program directors and instructors and people and medical directors. Right? I know for me as a program director, when I submitted questions to registry and did that whole thing, I knew it was by the sheer idea that you guys could see those questions. Right? And I'm not going to write questions intentionally trying to confuse my own students or our, students that are going to try to take that test. Right? We're trying to make them just black and white as much as possible, as long as you just understand kind of test taking strategies and you understand the concepts. Right? You should be able to work your way through most of the questions. Right. So again, that head and face, like I said, that's the big one that will cause some confusion. Right. And then the torso being 18%, so the chest and the abdomen being each 9% as well. All right, so question says, so does the neck get included with the head, or is that a separate 1%? I would include, it starts to split hairs. It's like, all right, well, does the torso kind of include the neck, or does the head kind of include, everything above the shoulders is the head? If it was me, I'm going to put it with the head. Right? I'm going to put it with the head. I know our current books don't isolate it out as a different percentage, right? But if we had that patient, or depending on how it was described to you, right, you could probably figure out pretty quickly, just thinking about, okay, if they say the front of the neck is burned, go to that Palmar method and say, okay, that's, 1%, maybe 2% for the neck. I'd kind of do it that way. If it was a small little area that they were describing, like just the top of the hand is burned. Well, that's the same as the palm, so I would do 1%. Right? Most of the Rule 9's questions that you see are going to be off of the arm and the leg and the chest and the head, right? They don't generally get too nitpicky on small little regions, right? Those small little regions, like just a neck burn or something, is going to shift better to using the Palmar method. Right? And it's something that even kind of testing center, taking that multiple choice test, we could, kind of do the same thing. You could be sitting there in that testing center saying, okay, they're telling me the neck is burned. Well, if my neck was burned and my palm is 1%, like, all right, I would legitimately be sitting there in the testing center being like, all right, well, my palm is covering, okay, that's probably about 1, 2, 3 palms to get all the way around my neck. So 3%. So what test question is kind of closest to that 3%? That's probably how I would break that out. All right. Hopefully that answered that question. So good percentages that you just have to know, right? Have to know. Now, moving from an adult, right, to a pediatric patient, and I'm going to erase these percentages on this side, just to open up a little bit of space. So moving from adult to infant, and so we take the same, here's our baby, those are same. The nice part is it's easier to just remember what's different than to try to think about remembering or memorizing a whole bunch of different numbers. So one thing we know about kids is kids have big heads. Right? They have huge heads in proportion to the rest of their body. Right? So what we do moving from adult to infant, the adult's head is 9. We're going to double it, and the infant's head is 18%. Right? Kids have big heads. We talked about they're going to lead with their head if they fall or if they get into an accident or something like that. Right? They're going to go head first. Right? Kids lead with their head. So double the size of the head. Right? So we added 9% to the head. The place where that comes off of is the legs. Right? So each leg is 13.5%, 13.5%, which is taking 4.5% off each leg. So we added 9 to the head, we're going to take 9% off the legs. Right? So we're going to do 4.5% off of each leg. Everything else is the same. The torso is 18%, the back is 18%, the whole arm, each whole arm is 9%, each, the genitals are 1%. Everything else is the same. All you got to remember going from adult to infant on the rule of 9's is double the head and take half of that off of each leg. And so the only numbers that change is 18% for the head, and it looks weird, but 13.5% for each leg. That's where we did. Each whole leg had 18%, minus the 4.5% gives us that 13.5%. So we're gonna do that off of both legs. So we added 9 to the head, took 9 off the legs total. So 4.5 off each leg. I'll tell you, most of the Rule 9's questions I think about and everything are typically adults, right? But that's kind of the quick and easy way to move to infant, right? Quick and easy way to move to infant. So infant, again, we're really talking 1 month to 1 year definitionally versus adult, which you could pull in adolescence. Right? And so the question becomes, all right, well, what if they give you a child? Right? They give you a child. Honestly, I would split the difference. Right? So somewhere between 9% for the head of an adult and 18% for the infant, right? Depending on the age of the child, it's going to be somewhere in between. So maybe it's halfway in between. Okay? And then I would do the same thing for the legs. Honestly, I've never memorized the child one because I got the adult, I got the infant. I could split the difference and I'll find the answer on a multiple choice test that is closest. It's a good kind of test taking strategy. I mean, obviously it would be ideal to just memorize the whole textbook, right? But it's just not practical, right? So you got to kind of remember patterns and you got to remember kind of shortcuts that are going to get you there. All right, so I memorized the adult and I memorized that shift to infant. So if I got a multiple choice question that described a child that was burned, well, I know my percentages for an adult, I know my percentages for an infant. Arms, chest, back, all that stuff stays the same, right? I would split the difference with the head, split the difference with the legs, and one of the multiple choice question answers is going to be very, very close to that amount. Honestly, that's how I would do it. And then again, I mean, for percentages and rule of 9's, now you just remember in 2 things. You're removing an adult and infant because we got a lot of other stuff that we got to remember too. Right? And we just got finite mental space that we're dealing with, right? So instead of remembering the adult and remembering the child and remembering the infant, remember the adult, remember that slight shift to infant, and then you can split the difference to find your child, and you're going to be pretty accurate with it. Just remember the arms are 9% no matter the age. The torso is 18% no matter the age. The back is 18% no matter the age. The genitals 1% no matter the age. The only thing that changes is the head gets bigger as you get younger, and the legs get smaller as you get younger. Right? So those are the numbers that move opposite. Head gets bigger the younger you are, and your legs get smaller the younger you are, as a percentage of your overall body surface area. All right, so complications, right? I think we hit on all these, right? Said airway complications, right? If there's any sort of burn involving the head, the face, the airway, sometimes they'll describe it as soot around the mouth, or in the mouth, soot in the mouth, soot around the mouth, or singed facial hairs, singed eyebrows, singed nasal hairs. Those will be some of the clues that they're trying to tell you to make you identify there's a burn involving the airway? And the answer is going to be a really aggressive airway management push. And then we said as well, just because we burned all of that skin, we compromised the integrity of the skin. Now the skin's not going to be able to help keep that warmth inside, so we're going to be radiating out a tremendous amount of heat. So as kind of backwards as it seems that we have a burned patient that we're actually worried about going hypothermic, that is actually the case. That's what we're worried about. So we're going to treat for that hypothermia, and keep that patient covered, keep them warm. Compartment syndrome, we talked about as well, right? As that tissue that gets burned, certainly if we have one of those circumferential burns that made it a severe burn, right? That tissue starts swelling, it's going to cut off circulation. It's going to impinge the nerves and cut off sensation to that extremity or whatever it is, right? And so as with any tissue, if we cut off circulation, that tissue will start to die, right? It's going to start, the cells are going to start dying. They're going to get electrolyte shifts, like you get a lot of potassium that'll move into the bloodstream, a lot of acidosis, right? That's going to build up as well in there, right? So that's very much related to it, right? And again, kind of the analogy with that burn compartment syndrome is almost like there's an internal tourniquet that's cutting off circulation. But that tourniquet is just that pressure that's building up in there because of that third spacing of that fluid that's shifting out of the cells and out of the blood vessels into the tissue or into that interstitial space. And then with that edema fluid shifting, right, is our hypovolemia, right? And hypovolemia is we're talking about how much fluid is actually inside our blood vessels. Because that fluid shifted out into the tissues, we don't have enough fluid now inside our blood vessels. So in a way, we're dehydrated, we're hypovolemic. Right? So fluid resuscitation, which is where we're going to wrap up this stuff in a bit, fluid resuscitation is a big thing. Right? We have to be able to get a lot of fluid on there. On the ALS side is our fluid boluses for this patient. We said the compromise of the skin, right? Now it's not keeping the outside stuff outside, so much more likely to have that infection, have an access point into the body because the skin has been compromised. Not something that's going to happen instantaneously, but a big concern that they're worried about in the continued management of this patient, in hospital and at the burn unit and everything from there. Acidosis, we said, heavily tied in with that compartment syndrome, just as those cells get deprived of oxygen, right? Going back to this morning on the shock stuff, right? If you get deprived of oxygen, instead of just making carbon dioxide as a waste product, if you're depriving them of oxygen, your body starts breaking down fat and muscles, and it creates things like lactic acids. So it drives a continuing of an acidosis in these burn patients. So treatments, first one's that, classic BSI scene safety, right? Some of the students that come through that, work for the fire service, their mind is still in that firefighter mentality, and they think about going interior on a fire, getting the hose, putting the fire out, doing those things, right? But for National Registry, for us, we have to isolate any other training that we have and say, I'm an EMT or a paramedic, and my job is treatment and transport of the patient. My job is not also to put out the fire, or also to go interior, or also to, be a law enforcement officer or anything like that, right? You have to isolate your mentality just to, I treat and transport patients. So anything else is not my world. So if there is a scenario question that says you arrive on scene, the house is on fire, you see a patient unconscious inside the house, what do you do? A lot of people are like, go inside and get him, but the house is on fire. This registry is kind of testing you. You got to separate it and say, scene's not safe. We're going to call the fire department to come do that. And for those of you that are on the fire department, you got to forget that you're on the fire department when you're taking that test. And you really have to limit it and say, the scene is not safe for me and my training as an EMT or paramedic. And the second one, stop the burning process or get them out of that environment that's causing the problem. Right? So sometimes they'll phrase it, the fire department brings you a patient and the clothes are still smoldering on the patient. Well, those clothes that are still smoldering are continuing to burn the patient. So the first thing we got to do is stop that burning process. We got to get that burning, smoldering clothes off the patient. Right? That's what it means by stopping the burning process. Right? Or if you spill something that's scalding hot, right? And to stop the burning process, we're going to immediately start flushing it with cold water, right, to start cooling it off. Right? We're stopping the ongoing burning process of that tissue. Right? So one of the immediate things, stop the burning process. Then we're going to continue with our primary assessment, manage our ABCs, push towards that shock treatment. Right? Keep them warm, we said, for the hypothermia consideration. High flow oxygen, supine more than likely. But keeping them warm is a big one. On the ALS side, adding in our fluid boluses because we know we got some funky fluid shifting that's happening. And we're keeping a very close eye on anything that tells us that airway is involved. And again, that one is going to push towards a more early aggressive airway management. Right? Like maybe we push towards intubation a lot faster than we might normally for a patient. Right? The appropriate initial answer is still OPA, BVM, but we're going to be ready to go pretty quickly on the intubation side. And then on burns, burns get dry sterile dressings for us. Burns get dry sterile dressings. Right, what we don't do in terms of kind of national registry scope is we don't do any sort of ointments to help it, or the petroleum infused gauze or anything like that. Like we just don't get into it. They tell us burns get dry sterile dressings. Right, you work in the hospital, you might get to do other stuff. You work in the burn unit, you'll certainly do other stuff. Right, but for kind of classic initial entry training right now, burns, we treat with dry, sterile dressings. All right, so do some couple questions. And I'm going to give you guys a few minutes to kind of go through it yourself. You can read the question. I don't need to read it to you. And then in the chat box, if you feel so inclined, you can, let us know as a collective group, or you can just private message it to me if you're not super sure and don't want to put yourself out there for it. Or you can just, think about it yourself and come up with your own percentage. Okay. So I'll give you guys a couple minutes and then we'll break it down together. A few answers coming through. It's a very good point, Leslie. Very good point in there. All right. Yeah, so let's start working our way through. So a 32-year-old male who suffered burns to his face. So this is one of those ones that I said it's going to try to throw you off. Right? The face is 4.5. So the whole head is 9. So if they specify just the face, do half of the whole head, just do 4.5%. I actually did both, really just to kind of test everybody. The chest is 9%. So the torso is 18, the chest and abdomen is 18. So just the chest is 9%. Then it says bilateral, so both anterior arms. Well, the bilateral entire arm is 9%. So just the anterior, right, the whole front and back, anterior and posterior is 9. So just the anterior is 4.5. But it says bilateral, so it's both arms. So 4.5. So we got 9 plus 9 is 18 plus 4.5 gives us 22.5. Good job. All right. Cool. All right, second one. Give you guys a few minutes to read it, think about it, and we'll talk about it. Yeah, everybody's going spot on with this one. This one's really just a test of if you were paying attention 10 seconds ago when I was talking. Right, this was right at the end, right? So you should do what? Which is also a good point to make on test questions is when they phrase it that way and says you should, then you got to look at it and say you should do what first. And sometimes that's where people get, all upset, on the National Registry questions because they look at it and they're like, well, I'm going to do all of those things. Okay. I'm not going to do all of these things. I might actually do all these things. I'm probably going to do all these things. Right? So you look at it and you say, I will do, right? You should do what? Well, I'm going to do all of those things. Well, then you got to put them in order. and say, which one are you going to do first? And which one are you going to do first is heavily tied back to like the National Registry, like patient assessment skill sheet, where it puts everything in order, right? That's what they mean when they say you should. It's you should do what first, right? And we go least invasive to most invasive, or BLS to ALS, right? However you want to phrase it, put it in order. So the very first thing we're going to do is what I said. Let's stop the burning process. After the scene safety, personal safety thing, we're going to stop the burning process first. Then we're going to open and assess our airway, probably using a jaw thrust because this is trauma. And then depending on how the respiratory effort is going, we'd probably start assisting ventilations, followed by potentially packaging that patient for transport. Right? So if we were order basing them, right, we would probably go in that order. But the first thing we're going to do is we're going to stop that burning process, right? Get those smoldering clothes off of them so that they're not continuing to be burned by that. Right? And then we will for sure do A. We may do B. Right? Hopefully that makes sense. We may do B. Right? They're unconscious, but we still have to assess their breathing. Right? If they're unconscious and they're breathing 20 times a minute with good tidal volume, everything's looking great, then it might not be appropriate to start bagging that patient. Right? So we can't add stuff to the question that's not actually there. If the answer is going to be to bag somebody to assist ventilations, we need something in the question that says cyanosis, shallow breathing, right? Something indicating that there's a compromise to that respiratory effort. This one though, we're going to definitely stop that burning process first. All right. One more here, and then we'll do Parkland Formula for a minute. Cool. Everybody jumped in well on that one. After applying high flow O2, treating for shock, burn treatment is dry sterile dressings. Okay. Not moist sterile dressings, not antibiotic infused, not petroleum gauze, not anything else. Dry sterile dressings is what the typical recommendation is. Awesome. Cool. So those are the questions. Just a couple questions, just kind of get our minds thinking and kind of evaluating knowledge a little bit. But for the last few minutes, I wanted to hit on the Parkland formula for fluid resuscitation, which the Parkland formula is designed to figure out basically how much fluid are we going to give a burn patient in the first 24 hours after they're burned. So for the entire next day, right, they just got burned, for the entire next day, how much fluid should we give them? Right, we said we have a big hypovolemia situation because of all that fluid shifting that's happened in a severe burn patient. Right, so when we get all that fluid shifting out of the blood vessels, right, that blood pressure is going to start tanking. We're going to go into shock. So we got to give that IV fluids to restore them. So we actually give a lot of fluids, And so there's this little equation, and there's a few out there, but this is the one that we're going to use. Right. So the Parkland formula is 4 milliliters of fluid times the patient's weight in kilograms times the total body surface area burned percentage. And that equals the amount of fluid in the first 24 hours. Okay. Whatever number that comes out to, we're going to give half of it in the first 8 hours. So we're going to front load it a little bit. And then we're going to give the other half of it in the remaining 16 hours over the course of that 24-hour day. Right? So this math is going to come out to this big number, a lot of fluid. We're going to give half of it in the first 8 hours. So we're just front loading it a little bit, and then we taper it off a little bit for the rest of that day. Right? And you can look at this and you say, but my transport time is 30 minutes. I'm not going to be, dealing with my patient for, 18 hours that I need to figure this part out. I get it. That's true. Right? But they have this formula because they want us kind of thinking about beyond just, here's my limited time to interact with my patient. Right? They want us to have a better kind of idea clinically of what's going on and what will continue to happen with that patient afterwards. Right? Just because we gave them a fluid bolus in our 30-minute transport did not fix the problem. Right? They're going to need a lot more fluid over a lot longer period of time. Right? We're just getting a start to it. So they want us to still understand the kind of longer term process of this. Now I'll tell you most of the questions, right, or the questions that I can kind of picture and think about or would anticipate with this stuff is the way this question would be built on a test is they would say you have a patient that's been burned on their head and their chest and their right whole arm and their left whole leg. How much fluid are you going to give in the first hour? Right, so they really sandwich together the rule of 9's and the Parkland formula. Right, so they make you figure out the percentage that they were burned based off of your rule of 9's, and then they see if you can actually plug that into the Parkland formula. Right? Okay. This is obviously on the ALS side. We do this not on the BLS side. So for this, if you get your burn percentage wrong, you're screwed because you can't actually do the Parkland formula correctly if you have the wrong percentage, right? So it sandwiches the both of them together. If you can do that well, consistently, then you've really got this anchored in and you're going to be great on any of these questions. So let's say our patient weighs 100 kilograms, so I can do some easier math. And let's say we figured out our rule of 9's. And our rule of 9's said our patient has a total body surface area burned of 45%. So we're going to do 4 milliliters times the weight in kilos times the amount that they were burned, so 45. Right? My calculator here. 4 times 100 times 45 is 18,000 milliliters, which is 18 liter bags of saline or lactated bringers, just depends on what your kind of protocol is for burn treatment fluid choice. 18 liters of fluid is an astronomically large amount of fluid to give a patient. And yes, we're doing it over 24 hours, but still, that's a lot of fluid, right? And think about a liter bag of saline, 18 of those is a lot of fluid. So remember, we've got 18 liters, so we're going to do 9 liters in the first 8 hours, right? And 9 liters in the remaining 16 hours, right? We take half of it and put it in the first 8 hours. So we're going to do 9 liters in 8 hours. 18 liters total overall over the course of the day, 9 front loaded. So a question that's there, does this only go for severe burns or moderate? Severe and moderate. Not usually superficial. Not usually superficial, typically just severe and moderate. So the question, right, and then it just becomes math manipulation. Right? Once you get your total amount of fluid, right, you got to look back to the question and say, and read what it says. So if it says how much in the first hour, right, then we could say there's 9 liters in 8 hours, right? So we could divide 9 liters by 8, right? It's a little bit more than a liter an hour. Right? So if we're going to do 9 liters over the course of 8 hours, that equals 1.125 liters per hour. So if the question was, how much are you going to give in the first hour? Well, in the first hour, it would be 1.125. If they said in the first 2 hours, you could just double that, so it'd be 2.25 liters. If they said how much in the first 30 minutes, right? How much in the first 30 minutes? Then we could say, okay, 1.125 for an entire hour. So if we're only going to do that for half an hour, we'll divide it by 2, and then that'll give us another number, right? As you can actually kind of peel it down to whatever time interval that they're giving you or that they're asking you. Probably something more like, you know, how much fluid in the first hour or in the first half hour, and something a little bit more likely for the realm of time that we're probably going to be interacting with the patient. So this is how we'll get it. Again, they'll describe the burn patient to you, tell you how much they weigh, and then they'll ask you how much fluid are you going to give them in a certain period of time. So it tests your ability to figure out your rule of 9's appropriately, and then tests your ability to plug it into a Parkland formula and be able to actually manipulate that down to whatever sort of time interval that they're actually asking. All right, so I'll tell you kind of anecdotally, because the question is like, it's a lot of fluid, and so fluid overload becomes a concern, right? It's always a concern. Anytime we're giving IV fluids, it's always a concern that we cause fluid overload, and fluid overload shows up in our lungs first before anywhere else. Right? So ultimately, what's happening on such a massive scale for somebody that's been severely burned enough is there's actually so much fluid shifting that's happening that the likelihood of us fluid overloading them compared to the rate that that fluid is shifting out of the blood vessels into the tissue is unlikely. Right? So it's actually going to be safe to keep giving them this amount of fluid. Now, obviously, if you listen to those breath sounds and they're just completely drowning in fluid, right, then we do have a problem. We need to manage the airway first, right? Airway and breathing first. But the anticipation is that fluid shifting out of the blood vessels into the tissue is probably going to be enough that their lungs are probably going to stay clear, and we're going to do it, right? But that starts to get us into an actual patient scenario where we start to say, okay, well, but what if they do have that pulmonary edema? Well, airway and breathing come first before circulation, so we would prioritize the airway and breathing for it. But really it becomes fluid, honestly, is what they need. Right? Kind of like the same thing with some of our sepsis protocols are going to like 60 milliliters per kilo of fluid, like a lot of fluid. Right? It's going to be hard to fluid overload those patients compared to somebody that doesn't have such a critical, severe thing going on for it. So that's kind of my kind of disclaimer answer on that. Is you are going to factor in airway and breathing for sure. These questions that you'll probably see in terms of tests and everything are just going to be kind of a straight plug and chug of the numbers, right? They're going to probably ask you other questions later to assess your ability to make sure that you're not fluid overloading a patient. You know, that's a very real world, a very actual patient thing that we're monitoring and keeping an eye on for it. Now, anecdotally, which is not textbook, not national registry, just my experience. So I transported a patient one time to our burn unit, and At the Parkland, like we were running fluids, right? It's basically just nonstop fluids for a while. So we were running fluids. We get the patient. He was pretty stable all day. It wasn't like a massive, crazy, severe burn, but it was a good burn. So we were definitely thinking about this, and we went to the burn unit. And I lingered around for a little bit, and I was talking to one of the doctors that worked in the burn unit. And I said, "Hey, doc, so Parkland Formula," and he was like, "Yeah," and he didn't even let me finish the question. And he said, "Look, honestly, for you guys and for, where we're at and having such comparatively short transport times to get to a burn unit," he said, "honestly, just keep running fluids." He was like, "In the event that you manage to fluid overload a patient, it's much easier for us to deal with that than it is to have that patient crash because they weren't getting enough fluid in the first place." So his answer, not a textbook, not a national registry thing, not anything like that. His answer was, it would be better to have too much fluid in the system that we need to manage the airway, as opposed to not have enough fluid in the system and that blood pressure actually bottoms out and they go into cardiac arrest. So his kind of takeaway, his kind of simplistic way for me, he was just like, just give fluid. If you manage to overload them, we can deal with that better, more easily than we can if that pressure drops out and they actually go hypotensive or they go into cardiac arrest from it. So that was a super great takeaway. I've always remembered it. But again, for us, textbook, national registry, right? Signs of pulmonary edema is that contraindication for the fluid resuscitation, right? So if they give you some pulmonary edema signs, we're going to withhold the fluid. Right? That is, honestly, it's just probably not likely to get pulled into a Rule of 9's Parkland scenario multiple choice question, right? But it's a very valid concern for sure.